Hello, and welcome to another edition of my search for the truth, the whole truth, and no dogma. I'm joined again by Dr. Bill Hang from the US. We're discussing airways. We're discussing whether orthodontics can impact people's airways. The interest in airways within orthodontics, within dentistry, probably within the general public, with this whole interest in breathing and sleep apnea, is the whole subject that's grown greatly. And there are a lot of people who are now working as airway orthodontists. I think Bill was the first into this. He was coming up with great ideas and also some observant criticism. Now, if we are sensible in our question, we say if there are airway orthodontists and they're doing something to help protect, improve the airway, then is it possible that airways could be negatively impacted? And there's always going to be two sides of every story. And that's what I want to bring Bill Hang on to talk about today. And so, Bill, what's your view on this?
Well, my major view is what I learned from my patients and what they tell me when I'm treating them. And that's how I really got the interest in the first place, was listening to my patients. And one in particular, over 30 years ago, who had serious temporomandibular joint pain issues, but she mentioned to me that we'd had an appliance in her mouth and she felt great, but when it broke and her jaw fell back, she couldn't breathe. That made me look at her lateral head x-ray and realize that, gee, the airway is small. And I didn't even know what the norm was, but I figured that out talking to other people, and it caused me to focus on the airway for every patient. And since that time, I've heard so many patients talk about their airway changes, even with very, very minor changes in the position of the front teeth retracting very slightly, and someone says, oh, that doesn't work okay. That slide right there shows that woman's airway, how small it is, and it's a 2 or 3 millimeters at the base of the tongue, and that number should be 10 or 11. So ever since that time, about 1992, that's what I've been focusing on and learning from all the patients that I treat, many of whom have been retracted before, and I was reopening their spaces for them where they'd had the teeth taken out, and they would say, oh my gosh, now I can breathe, or things like that.
And then did you become critical about the impact on airways by certain forms of orthodontics?
Well, originally I'd been extracting and retracting teeth in my early practice like crazy. And when I got away from that, but for aesthetic reasons, that was one thing. But then when I started to listen to my patients, and they were telling me when I was reopening spaces for them, and they were telling me they could breathe better, I began to think there's a lot more to it than just looking better. The more I looked at it, and the more I then got into the whole sleep thing, learned about sleep studies, and I realized how big of an impact it was. And pretty soon my practice was filled with people who had legitimate breathing and sleep issues. And my focus then began to be on how can I help them? As I reopened spaces and or did orthodontic surgery to bring jaws forward and saw improvements, then it made it pretty obvious to me that there was a very, very strong relationship between what we do or don't do and their ability to breathe or not breathe.
Excellent. So now let's move on here, because you and other people raised your concerns, and this eventually led to the American Association of Orthodontics holding a meeting in January 2019 on Marco Island, where they set about investigating whether or not orthodontics could have a negative impact on the airway. And we're not here, clearly we're not talking about all orthodontists. We're not talking everyone causes this. We're saying at times some people can be impacted. Okay, so Bill, tell me about this event.
Yes, well, I think it should be noted that I actually volunteered to help someone very important in the society to help direct what was going to happen. The person told me, no, we have it all handled. And I knew the person well, and I knew I had 20 years of experience that person didn't have. And I wasn't surprised when he said he didn't need my help. But so here we are. There I'm pictured at the meeting in Marco Island, and I like this slide because the conference title was Sleep Apnea and Orthodontics, Consensus and Guidance. And I've been in dentistry. I started in dental school in 1966, and I have never seen even one thing in dentistry that there's consensus on. Not one thing clinically that everyone will agree on. And I saw that title as being, that's an interesting title to have for a conference which is trying to find the truth. And this was a slide that was on the screen at Marco Island. It said, protecting the future of your specialty. And in reality, I was there because I wanted to protect my patients. I wanted them to be healthy. I wanted them to have long health span. Bring up the next slide, and I had some alternative titles I might have used for this. Optimizing health span for our children was one. And the next one, you can pull it up. Reclaiming our position at the center of healthcare, which we had 100 years ago, and I'm going to show that in a moment, that we really were doing that. Treating in the primary dentition for health reasons, as orthodontists did 100 years ago. And that's the truth. The orthodontic profession was actually treating in the primary dentition, and you can keep advancing the slides, and I think that will illustrate that.
So just to be clear for our non-dentist reasons, when we're talking the primary dentition and the ages people doing orthodontists, I mean, my grandfather was taught to expand at 4 or 5 years of age.
Yes.
And a lot of treatment often starts at 6, 7, or 8. And a lot of clinics I know won't take anyone over 10 years old.
Exactly. Yeah. So in reality, those slides that I just had there were talking about the fact that we're treating. Here's a orthodontist back in the early 1900s, and he was treating regarding mouth breathing and talking about treating very, very early, under age 6. Words are very important here, where he's actually talking about brain, down there on the bottom, it says, even the brain development is retarded. Now, no one uses the term retarded anymore, but here we are in 1909 talking about that very issue, neurologic development being changed because of reduced oxygen saturation. Doesn't come out and say that, but now we know that's what it is.
Yeah, well, he doesn't know exactly the process.
Exactly. So what's interesting is I have some more slides here. If you go through them, the history of the profession. The next one says in 1915, it's all about treating very young and the cooperation between rhinologists and orthodontists. These are not new ideas. They've been around for many, many years. And here we have something talking about an obstacle in the way of free nasal breathing. We don't want that. We want people to be able to breathe really, really well, easily. And just go through the next couple slides. You can see here, again, it's a concern that goes way back when. Here's one about efficient breathing and improved in general health. To be honest, most of the orthodontic articles don't ever use the term health, and yet, they should. This slide right there talks about the final draft was completed. The final draft of the white paper was completed prior to the Marco Island meeting, and not even the first speaker had spoken when they said that the final draft of the white paper had been completed.
So, Bill, let's just, for everyone watching, let's put this into perspective. So the objective of this consensus event in Marco Island was that the American Association of Orthodontics was going to come out with a white paper. And what you're suggesting here is that white paper was written before the event even occurred.
The moderator actually announced that the final draft had been written, and this was before any speaker spoke, and it would be released within a few weeks after the meeting. I later talked to one of the people who was an author on that, and he said that white paper was actually written in 2017. Now, I can't confirm that, but that's what he told me, and he is a signer on the white paper, one of the few, or one of the several.
Now, what interests me again is that you, I think unquestionably the first and probably at the time the biggest figure in Airway Orthodontics, was not given any opportunity to raise your concerns. Were there other of your colleagues in the field somewhat or mildly or majorly critical of the the current thinking who were invited to present?
No one was invited to present. There was one person who was invited to present, who was very critical, and I have slides of him. He was really the most published person in all of sleep. He's now passed away, but Christian Guilleminault is his name. He is a Frenchman. Yeah. He passed away, about later that summer in 2019. But he had more than 400 articles in the refereed literature, and was probably the best known name in all of the entire world on sleep.
He came out with the term sleep apnea.
Exactly. He came up with and the category of mild, moderate, and severe sleep apnea. Anyone who's in the sleep arena would acknowledge Dr. Guilleminault as essentially being the father of the entire movement. He was a speaker at the meeting, but the white paper was written before, and he was not even asked to be apparently was not even asked to be, because he's not a signer of the white paper. But he would have been the logical person in the world to be the best authority, in my opinion, since he had, experience in this arena than anyone else. You can flip the slides and you can see some of the. Yeah.
Was there any comment? You've got, yes. So here's Christian Guilleminault.
Yeah, that's a picture of him. And these were statements he made on that first day. Orthodontists are still using headgear, which can kill a 12-year-old. He then later in that same talk said, you must stop pulling teeth and you must treat as soon as the problem is recognized. And he focused on treating really early in the primary dentition. And all of these statements were essentially ignored. And any one of them would have been a very important part, really what I would consider a proper consideration of the whole subject at hand. And if you wanted to have the white paper have real credibility, having his name on it as a signatory would have given it real weight, in my opinion.
Yes, but he didn't necessarily agree with everything that was being said or was going in, or the consensus.
Yes.
Then we've got a quote from Guilleminault coming up.
Here's another one. These next ones are some quotes from the literature regarding this whole issue. Here he's talking about intellectual development, and this is back in 1981. Again, this is mental kind of stuff, brain development, cardiovascular systems. And he talks about how the entire upper and lower jaws are affected with chronic mouth breathing and the face doesn't grow forward. He's very well known for this.
Yeah,
but
put
again,
this here, Bill. So we're saying that if orthodontics does negatively impact the airway, this can go on to cause issues with intellectual and cognitive development. And that clearly raised an alarm with the American Association, with all orthodontists. And then the American Association of Orthodontics decided to have this meeting on Marco Island to come to a consensus. Well, right. I don't think they were looking to get a consensus. Again, I totally agree with you. It was a wrong phrasing, but clearly to investigate.
Right.
And they came out with. So, what were the sort of conclusions of this?
Basically, that there was really no relationship. They had speakers who cited their own research or didn't. Said that there was no relationship, and they talked about expanding and it didn't affect. The fact is they would only expand 3 or 4 millimeters and didn't really do a lot more than that. I couldn't argue with them because what they didn't show any relationship at all. But that didn't mean that there are not things in the literature that say otherwise. This was one of the quotations from one of the speakers, that there's really no relationship, and that was from his own research. And I put this in here because any child with a mobile device could find these articles. And here's one. Go back to that slide. That you can read the conclusion on it. Here, number 1, the pharyngeal airway size became narrower after this treatment. Here's another, number 2, and again, larger incisor retraction leads to narrowing of the upper airway in adult patients. This is out from 2012. This is well before this meeting. So there's several more.
Was available, and
this information was out there. It was not presented, and anybody who's a researcher, I would think, would go do a literature review and find out what others had published. I mean, that's what academic people do. You expect them to know the literature, and if they don't know it, to know how to search the literature and find out what's been published. Here's another one. Again, this is 2010, and you can see it has a reducing effect on the middle and inferior airway dimension. And this is Guilleminot's article himself, and he's talking about when you have missing teeth, there's a greater chance of sleep apnea. Doesn't specifically say anything about retraction, but talks about missing teeth. And here he further talks about how this can predispose to collapse of the airway, and patients can later on present with sleep apnea at a later age.
What he's doing, he's looking at people at a later age who have sleep apnea, and he's making the observation that if they've had missing teeth for any reason, but in our area of interest is they've had those taken out for orthodontics, then that's a risk factor.
Yes, exactly. There are a couple more in here if you want to go through them. It'll help the audience really see. And here's another one that talks about in Class 2, Division 1, why you wouldn't want to retract.
That's where the bottom jaw set back.
Exactly. The last thing you want to do because their airway is already compromised. The next one talks about flow of the air, which is really important. This is the most recent kind of thing, pharyngeal air flow. And this talks about pharyngeal collapse being higher after extraction treatment. The idea here is not just the size of the airway, but whether it's more subject to collapse or not. And that's a big issue. A lot of the research that you're now talking about that. Here's another conclusion from that same thing. Everybody is free to read that. The point being, there's plenty out there for people to see in the literature. And if I had been asked to speak at the meeting, I would certainly have wanted to have cited these articles. Again, I'm not a researcher. I'm a clinician, and I'm not your person who knows all about statistics and how to design studies. But I do know that the refereed literature has people who look at these things and they don't get into the literature unless they pass certain criteria. And if we say we're evidence-based as a profession, then to me that means we look at the literature that's out there and then we change what we do based on what the research says. If we don't do that, why are we doing the research in the first place? It doesn't make sense to me.
Yeah, I think this is okay, and I don't want to try and allude or try to pick up on a hypothesis for why this wasn't going on, but of course, it's one thing to have a problem. You know, lots of professions have had problems, lots of issues, things have gone wrong, we've learnt from our mistakes. I think the telling tale is what happens when a problem is highlighted and how a profession deals with that. And this sounds all wrong, Bill. You know, I've heard many other people saying this, but this whole Marco Island white paper, I've heard it called a whitewash.
Yes, I've heard the same thing. Absolutely. Many people are skeptical about it, and I don't frankly blame them. I have a list of the people who signed it, and I don't have their names on it, but later on in the slides here you can see their backgrounds. If you want to flip forward, you can see the people and their backgrounds. Now, here's just quickly another talking about the headgear, which we talk about extraction, but here's a girl who wore a headgear for 8 years. Now flip to the next slide, and you can see that her airway dramatically decreased in those 8 years. And I'm not going to say that it was a direct result of that, but all I can say is that airway on the right-hand side is certainly not one that I think is consistent with someone having a long health span, being healthy and their entire life. You'll notice
not optimal health.
Yeah, and go on to the next because there's another article out of the refereed literature
I like
here.
This one again. Big full screen, Bill, for a second.
These are some more articles.
What I'm saying here is that a child should be able to find these articles. This is not complex. If anyone's watching this, it's not difficult to find these articles. You could look at the title, take the author's names, take the publication date.
Yes. Here, now you see, even out of the literature, going back to 1967, cervical headgear causing a downward and backward rotation of the mandible. We know now that if the mandible goes back, the tongue goes back. If the tongue goes back, the airway is going to get smaller. Now, there's several slides here out of that main era in the 60s, and if you go through them, you'll see that this is well known. Go to the next slide. Number 2, And here we see excessive downward movement of the chin with cervical headgear, and we don't get the normal forward chin progress. Okay, that's
this is
well-known
the downswing in facial form, basically the tongue being carried down into your airway.
Yes, exactly. So there's some more here. Go through them quickly, and then people will understand that this has been out there. Here again, indicate inhibition of forward growth. Another one here, the use of Klein face bow, downward and backward growth. We question the use of directional force. Here's a very well-known name, Merrifield. People in the orthodontic profession know this guy's name, and yet this is ignored. Go another slide or two, and you're going to see. Here we got another one, and strong, such as a mandibular retrognathy to development of upper airway occlusion already exists. So these are articles that are saying this is not a good idea. This is 1999. Here's 2000. Again, these are out there. All of these regarding cervical headgear causing the growth of the face. Now, this is a very important slide I put in here. And there were 14 signers of the white paper, and 9 were orthodontic department heads or professors of orthodontics. 2 were private practice orthodontists. 1 was a lawyer. 1 was a staff liaison person, and 1 was an MD, a clinical professor of neurology and sleep medicine. And that was it, the only MD. What we're dealing here with is a medical issue. Now, dentists cannot, in most states, they cannot diagnose sleep apnea. You have to have an MD. And so if you're really talking about sleep apnea and wanted to have the most credibility behind whatever your conclusions are, from my perspective, you would have wanted to have had that panel that all signed that white paper be loaded with people with much experience in the airway arena and diagnosing and treating those who suffer. Specifically, that would be sleep physicians, MD specialists, sleep physicians, pulmonologists, or ENT specialists who do their specialty in sleep. The most logical one would have been Christian Guilleminault, as I mentioned earlier, the best known name in the world. I would have wanted to have him there as the man in charge of the whole research project. He would have made, for me, if I were selecting the people, I would have selected him first.
Yeah, and I had him there actually to listen to his input rather than just as a figurehead, which there is concern he was just a figurehead to help the rubber stamping process if that was happening. Now, clearly I've been asking for debate on the etiology, the cause of crooked teeth. My father did this many years before me. But essentially, I'm calling for debate. As I say, full, free, and fair. And when we mean free, I mean everyone's invited. We don't have the wrong person excluded because they've got the wrong views. And it sounds like you and many others were excluded because you've got the wrong views.
I would have been happy to come had someone said yes, but I've had all that experience in the arena with people who I've treated successfully, those that I've tried my best, and they still have issues. And I don't want to let anyone think that I'm the person who has all the answers. I'm not. But with the amount of experience that I've had and listening to my patients, I think I have a lot to offer. And I've written articles about this kind of thing too. I've also talked to various orthodontic department heads going back almost 20 years ago, had conversations with them to express my concerns. And basically, no one wants to listen to me, it seems like. They can't wait to get away.
The implications are something that some people would probably not want to hear.
I guess so.
Now, we've got a slide here of the AAPMD, and this is set up by Harry. And can you talk to me about a bit this? Because we go the road future. Okay. Where are we going from here?
This is the best organization, I believe. And Howie Hendon and Michael Gill, more than 12, 13 years ago, had coffee one day and essentially decided that they were fighting forest fires with the people who had sleep issues and breathing issues and pain issues. And to them, it made more sense to prevent forest fires than to fight them. So they decided to form this group, the American Academy of Physiological Medicine and Dentistry, which wanted to collaborate and get people of various stripes, both physicians, dentists, and of all the different specialties in medicine and dentistry who have interest in this, to work together, essentially to be the biggest tent. And there was nobody had an agenda here. It's just, how can we be more effective at helping kids? And we realize, not just kids, but adults as well, we realize that people of all ages have these issues. And the deeper the dive you make into this, you realize it really is a pandemic. And it's all these breathing issues are correlated to every chronic disease known to man. Unless and until we take control of this, we're still going to be fighting forest fires when it makes more sense to prevent them.
Well, clearly, this video we're doing now, and my whole mission has been to raise awareness of these problems. I mean, the AADND
Exactly.
not only are raising awareness, but they're trying to find solutions. They're trying to bring people together. And clearly that's what we need to do. And of course, we've had this rapid increase in interest in breathing, and I think that James Nestor's book was just a huge leap ahead. It was, I remember he came to visit us. He stayed with me in my house. We visited Dad. He actually came and interviewed Dad at my sister's, me and my father at my sister's.
Yeah.
And then we stayed up because he was flying off the next day. So he came into London with me. And it seemed an age. It seemed something like 2 years. I heard absolutely nothing. I'd almost forgotten about this guy. And then all of a sudden, wham, the book lands. And whoa, this wave of interest. And it's not just, the waves are still coming. They still seem to come in. This book seems to have been one of many, but a really important turning point, getting that information out there.
It absolutely is. And interestingly, we should be doing this because literally Monday evening, this is a week ago tonight, I met James Nestor. We were in Greenwich, Connecticut, and he spoke at my grandson's school. He's now living in Portugal, but he flew in for that, spoke at my grandson's school. And my grandson heard him speak in the afternoon, and he was kind of skeptical, as young 15-year-old boys would be. But he said to me before I went over for the talk, he says, this guy really gave a good talk, and it was really very interesting. So it really resonates with kids. So for the first time I met James Nestor, he gave a very good presentation, and we had a nice conversation afterwards, and the parents came up quite a number afterwards. We're very, very interested in what he had to say. By the way, that said it was published in 32 languages. Nestor says it's now been published, I think, in 35 languages. And he's very much in demand, and his presentation is very, very good. And he's really raised awareness worldwide about this whole issue.
It is. I mean, it's you take someone like this from outside of our field to come in. He's a journalist. He's gone around. He's done the correct thing a journalist does. He asks people about things. Right. He gathers information. He puts it together, and he's put a brilliant book together that is explaining things to people. Bill, you and me, we tend to be too technical. It's our
exactly,
and it takes someone, a layperson, a journalist, to put something together to help get the word out there.
Yeah, and he did a great job with it. He's made all the mothers very, very aware. When I was still practicing, after that book came out, I had many people come in, and he mentioned my name in the book, and so a lot of them came in because of that. But these people were informed. The mothers were informed, and they're the ones who are going to change things, Mike. You know that, and you've done a great job of helping them be aware.
This out. But my dad said to me years ago, he said, "You're not going to get the orthodontic profession to move forward on this. You're going to have to go to the public." And so I've gone, when social media arrived, and I thought, right, that's great. This is going to help me go to the public. And I've gone, boom, straight through. And I've been I'm more successful than I was imagining to be. And this whole channel and this program we're doing here is off the back of that, to get debate, get answers. I've got this. Prevention is my big topic, and we're going to get there between understanding the cause, working out the pathology, and we're going to get that through full, free, and fair debate. However,
absolutely, you've done a great job, and I think Nestor just put it out there for everybody. The two of you have got worldwide attention for it, and once people see it, as they say, once you see it, you can't unsee it, and that's what's going to happen. The parents are going to demand it, and the profession, if they're wise, will respond to that and change appropriately. Or, to be honest with you, the profession will go away because it will be deemed useless, and that's very sad.
Well, if we were to look at the reasons behind a whitewash, it may come down to those last comments you just made. Okay, Bill, listen, it's been great chatting
Yep,
this evening. I
you
think
bet.
did we have one more slide? Some more interesting point you were going to make?
Oh, that you could show those slides. Put them up there. I love these slides because it says that anybody can do it. This is a picture of a woman driving her car in New York. She's an orthodontist, and that's her taking a picture with her cell phone of her son with his mouth hanging wide open. Now, the next view, and she's taking my course, learning orthotropics, and there they are. They lived in New York, but here they are flying back from California to New York because she brought her son for me to adjust his orthotropic appliance. And in the plane, you can see the father there with his mouth hanging wide open and someone else with it wide open. But this is the next slide, is the next summer in Long Island where kids are at camp. And you see the yellow circle around her son who has his lips together, and every other boy there has their mouth hanging open, which the point is, this is how widespread it is. Then show the next two slides, and you'll see here is Mason with his lips together, nice facial balance, and there's his father with a long face, both of them are football players, and the father has sleep apnea. Then there's one more slide here, which is even better. The mother sends me this before Thanksgiving each year, and that's her son with the lips together and another boy with his face blocked, but his mouth is hanging wide open. And he has that long face with the chin down and back.
Why the long face?
And you and I both know that his airway is compromised. So these slides just show that it is a rampant problem worldwide that's basically been ignored. This slide really puts science to it, and he's my hero, Ron Harper, PhD neurobiologist at UCLA, and he chronicles the brain damage that occurs with these people, even with one night of reduced oxygen saturation. So the point is, we have really good documentation in the healthcare arena about how important it is, putting numbers to what the people in our profession knew more than 100 years ago, only we have modern research with MRIs to be able to show this. And then here's this is a conclusion from one of his papers: the neural injuries accompanying sleep disorder breathing are extensive, and he then chronicles it. It's all his research does is puts into the literature what people knew intuitively more than 100 years ago. And then, of course, here's my hero, Patrick McCune from Galway, Ireland, and this book, The Breathing Cure, is really phenomenal because with each chapter, he correlates breathing issues with every chronic disease known to man. So for those people wanting to do a deeper dive, that's an excellent book that I highly recommend.
And I think I should make a quick shout out here that we've got the next Mewing conference. I think we haven't come up. I think we're going to be, it was called MewCon last time, and we might rebrand it to being the Mewing Expo. We're not quite sure yet, but that's going to be coming out on the 6th of September, and both Patrick McEwen and James Nestor are going to be talking. So I should give that a shout out at this moment.
That's great. I mean, everyone in the whole world should be interested in that. I mean, from a health
perspective. I'm trying to do this to the general public. That's my whole point.
Yeah.
I'm going to make this bridge here between all this information you and me have that the general public really wants to know about. And let's get it out there for them. And then, Bill,
absolutely.
Yeah, I'm going to say that we've talked about it, that when I do a consultation and I explain to patients the whole story of what's gone wrong and what the treatment's trying to do, I then sum up and I go, look, the short summary of this, the short summary of the treatment is stand up straight and shut your mouth. That's not a new idea, is it? Your grandmother could. In fact, I once had a patient come in. They bought the grandmother with them, and I know what's going on here. They're hoping the grandmother's going to pay for the treatment. So they come in and they sit there, and the grandmother's looking very suspicious. You can see from my body language, and we go through it, and then I say, stand up straight and shut the mouth. And then the grandmother pipes up and goes, I told you that. Yes, this is the treatment we're having. Doc, I'm all signed up. Let's go for it. And you can see the mother's a little bit, I haven't decided yet.
Well, that's the trouble is parents today, at least in the United States, aren't being parents anymore. They're trying to be the best friend of their child, which is the worst thing they can do.
There's another story.
They should take the example of the grandmother and be the parent.
Yeah.
And do that. The next thing that people say in those consultations is, and you've heard this a zillion times, why isn't everyone doing this?
Yes.
And then I just shake my head.
It's not easy to change people. It's
no,
a really
exactly.
hard thing to do. Okay, Bill, listen.
They all
thank you
say
very
it's
much.
common sense. Yeah, you bet.
It's great
Thanks, Mike.
speaking to you. Thank you for going through the Marco Wall and White paper. I really wanted that your opinion to be out there on this. All right.
Okay.
Until the next time, I'd love to do another one with you again.
Okay.
In the meantime, sir.
Okay, very good, Mike. Anytime I can help you, let me know. Goodbye.